Hello, everyone. I'm Dr. Carmen Pugliafito, and I'm here today with Dr. Roger Goldberg of Northern California. Roger, welcome back to Retina Synthesis.
Carmen, great to be back. Thanks for having me on.
You've gained extensive experience in the treatment of MacTel with the CNTF implant, and that's what we're going to talk about today. Can you start off by telling us what the prototypical MacTel patient presents and some of the key clinical findings that you'll need to recognize?
Sure. I'd say first and foremost is the patient very rarely gets referred to you as having MacTel, idiopathic macular telangiectasia type 2. Almost always they're referred in as an epiretinal membrane because they always, I'm going to give the whole thing, but in ERM, because they have this ILM drape sign where there's the ILM is draped over these cavitary lesions. They're referred in for cystoid macular edema. They're referred in for macular degeneration because they got RPE changes and some fluid, quote unquote fluid in the retina. Sometimes they're referred for DME. A lot of these patients have a diabetic mellitus as part of their past medical history. So they're very rarely referred in as MacTel. But when you see it and you start to recognize the common signs, it looks quite different than all those other conditions. First of all, for example, is it AMD? Look, they don't have drusen anywhere else, in the eyes. The pigmentary changes tend to kind of cluster, particularly on the temporal aspect of the fovea. Sometimes you can get this pigment clumping or even RPE migration into the retina. You can see those right angle branches. And I think, honestly, OCT, no one knows this better than you, but OCT now is the workhorse of the retina clinic. And there are just so many classic signs on an OCT where you see that temporal thinning because MacTel is really a neurodegenerative disease. It's not a vascular disease. So the telangiectasias, it's almost a misnomer. There's secondary vascular changes that take place. But you get hollowing out and loss of tissue, which is why you get these cavitary lesions. And just like what's left is like the ILM draping across, and you can get this pigmentary changes. Um, I think an FA can be helpful. It rules out, diabetic retinopathy. OCT angiography has some pathognomonic features as well, showing kind of increased vessel density temporal to the macula. And it can also be helpful, actually, if you're uncertain whether there might be a little CNV. These eyes can occasionally be complicated by choroidal neovascularization or retinal neovascularization. The neovascularization that's occurring isn't coming up from the choroid, it's actually coming from the retinal vessels. So it's probably best described as retinal neovascularization. But really, that's the only subset you can treat with an anti-VEGF. I find they tend to behave almost more like the myopic CNVs, where you can give them kind of 1 to 3 anti-VEGF injections, and that neovascularization goes away. And we now, with the approval of a medicine, this implant that's goes under the trade name Encapsulated, used to be called NT501, and the generic name is revakinagene taroretcel. And this is a surgically implanted device um, it's actually loaded with genetically modified RPE cells that have been programmed to secrete ciliary neurotrophic factor. The way I think about CNTF is that it's like Gatorade for neurons. It helps keep neurons alive. And CNTF is actually produced by Mueller cells. And Mueller cells, of course, are the primary cell type that's initially lost in MacTel. So you're providing this really important support that helps keep the photoreceptors alive and has been shown in the pivotal studies to have um, both anatomic benefits at slowing the progression of disease and functional benefits, slowing the loss of reading speed, slowing the loss of retinal sensitivity on microperimetry. So it's unlike, let's say, the GA drugs where we've sometimes struggled to find a structure function correlation. Here in MacTel with the Incelto studies, we do have a nice anatomic and functional benefit that's been demonstrated. across the clinical program.
What were the results of the clinical trial? Top line.
Top line results. So it was, the primary endpoint was anatomic. It was easy loss on OCT. And basically, if I were to kind of summarize it, it was about a 35% reduction in photoreceptor loss at 2 years. So that's the top line efficacy result. But again, kind of when you look across both the two phase three, excuse me, and the phase two study, we see clear functional benefit on microperimetry, on reading speed, best corrected visual acuity. I think of as more of a safety signal in this study. There was really no difference in best corrected visual acuity between the two arms. And the key thing in terms of safety, first of all, the CNTF can cause miosis or pupil constriction, and seems almost independent of the pupillary changes, can cause delayed dark adaptation. Seems to happen about 20% of patients, these two symptoms, not necessarily the same 20% of patients. And came out very clearly in the clinical trials. And most patients, it's mild, but because this implant is a one-time treatment that theoretically lasts forever, it is important to kind of let patients know about all of these potential adverse events or side effects from the medicine.
In terms
The,
of
the
selection, what's the natural history of MacTel?
Sure. So I'd say there is a couple key acceleration points, but it is a slowly progressive central macular disease. And I'd say the first key turning point is presence of an easy break. Once there's an easy break, the disease actually tends to accelerate quite a bit, and then eventually kind of takes over what's sometimes known in kind of research circles as the MacTel zone, but basically kind of an oval shape around the fovea, in roughly the central, subfield on an OCT. But once it kind of takes out that geography, it slows down again, and it doesn't tend to kind of spread out, and continue to progress out to, let's say, like the arcades. So there is probably this inflection point when it speeds up, and then another inflection point when, I don't want to say it burns out, but it's kind of taken out all the relevant tissue. And so the key is, when you think about Encapsulated, is when is the right time to intervene? If you're too early, maybe this patient was never going to develop photoreceptor loss and symptoms. If you're too late, uh, the treatment doesn't reverse the photoreceptor loss and vision loss that's occurred. So it's a little bit of a kind of Goldilocks situation. But one of the interesting post hoc analyses from the clinical trial basically showed that the best responders were those with smaller lesions or smaller areas of photoreceptor loss, less than a half a square millimeter as measured by OCT. And those patients, as well as younger age, which is kind of consistent with smaller lesions, um, tended to respond better. They had an outsized response when you do comparison to the sham treated eyes.
Uh, is there a gender predilection for this disorder?
So that's a great question. And some studies have suggested that there is a gender predilection, and other studies now, a lot of the original research and epidemiology work was done just using like color fundus photographs. You and I were talking about this before we started recording. We're now so good and we have such advanced imaging. Obviously, OCT is the workhorse. We can detect this disease very early. Um, Other things like FLIO, fluorescence lifetime imaging, ophthalmoscopy can also detect these kind of preclinical or subclinical patients. So I think the data is a little bit mixed on whether there's a gender predilection. My own gestalt in my clinic is I'm not really seeing that.
So tell us about the implantation procedure and anything else about case selection that you'd like to mention.
Yeah, sure. So this is a situation where you have to take the patients to the operating room. This is not in one-time in-office injection. It's a one-time in the OR surgical implantation. It's I think quite straightforward, but it's important to do each of these steps properly to prevent long-term complications. And that's what I was just able to present at Hawaiian Eye a week or two ago, was a root cause analysis of the surgical related adverse events. And it turns out a lot of it comes down to kind of suture management, which I'll talk about in a sec. But you basically make a conjunctival peritomy, you make a 3 millimeter sclerotomy, and the implant has a little titanium clip on the end, and you feed a 9-O-proline through it. We now actually make a little anchoring knot the superior aspect of that titanium clip. And then we take the double arm proline and run it through the sclera, but we're not using that proline to close the sclerotomy. That's really just to anchor the device, the implant, on the inner wall, on the inside wall of the sclera. We then use two 9-0 nylon sutures to close the sclerotomy itself, kind of placed a third and a third distance-wise in your sclerotomy. And then it's really important to rotate those 9-0 nylons to bury the knots, and to take the proline suture, which has these tails, to kind of take the partial thickness scleral bites and then trim the tails at the end of the sclera. So that way you don't have any exposure, because a lot of the adverse events came down to, the knot eroding through the conjunctiva, or the suture tails eroding through the conjunctiva. And then the serious adverse events, and there were 3 explantations across all 6 studies that have been done with this device in MacTel, 220 eyes. There have been 3 cases of explantation. And basically, what we've seen when we did the root cause analysis is that those were related, 2 of them, to the implant starting to extrude through the sclera. One of them was causing actually an UGG-like syndrome and recurrent vitreous hemorrhages. And another one was starting to extrude and poke through the not only the conjunctiva but the sclera as well. And then a third one was actually explanted, where it was related just to the suture knot causing a little localized subconj infection. Probably, because this device it is expensive, it can be removed, but some of these surgical complications, in my own mind, I think if they were to develop, I'd go in and say, hey, let me figure out how to reposition this, or put a little patch graft over it. But the first important step, of course, is just doing the surgery correctly, at the outset, rotating those knots, burying the tails of the sutures, having a good closure, so that these complications don't develop in the first place.
Is Neurotech, the manufacturer of NT501, having seminars for surgeons?
Yeah, so they actually will come in and into your office, and they have these model eyes, and where you can actually kind of walk through all the steps and basically implant a mock-up of the device using all the same sutures. 9-O-proline's a little finicky suture material. We don't typically work with that in retina. Um, and you have to tie these knots actually with the 2 needles still attached. It's a double-armed 9-O-proline. And so there's a little just kind of learning curve on that. So I would definitely recommend to do this wet lab with the representative from Neurotech. They'll let you do it as many times as you want. And they're really committed to making sure every case is a successful case.
Yes. Well, this is exciting. How common is MacTel?
Yeah, again, kind of from the old epidemiological studies, you might think there's only, I don't know, 10,000 patients in the US. I think that number is much higher, at least 25,000, again, because the original epidemiology was based on color fundus photography. We've got much better imaging now to detect these cases. I suspect a lot of patients historically were misdiagnosed, and said, oh, you've got macular degeneration or some other disease.
Yes. So it's a much more common disorder than we recognized.
Yeah, this is one of these rare diseases that's not so rare. I think if you were to go just to any retina meeting and just kind of wander the halls and ask patients, hey, do you ever see cases of MacTel? Everyone's going to say, yeah, I have these patients in my clinic. Whereas if, I don't think I've ever seen, I've certainly genetically tested for them, but I've never seen an RPE65 mediated patient, with RP and I've been looking for it because we have, as you know, a subretinal gene therapy for RPE65 mediated IRD, and it's very rare. Um, so this is one where it's not rare, and every retina doc has these patients in their clinic.
Well, Roger, thanks so much for this discussion. It is,
My
as I said, exciting.
It is. This is almost kind of science fiction come to life. It's amazing technology. It really is a platform technology because you can use this same type of system with these genetically modified cells, frankly, to produce any type of protein, not just CNTF. And it had been tried historically in like diseases like wet AMD with anti-VEGF secreting cells, and probably just didn't have high enough dose in terms of the amount of VEGF, anti-VEGF that was being secreted. The same or similar CNTF implants were tried in geographic atrophy, but this was in the era of time domain OCT before the rise of fundus autofluorescence. And so it, quote unquote, didn't work in geographic atrophy, but perhaps with next generation devices, larger payloads, and more advanced imaging, you actually might be able to show a benefit in GA. We'll see.
Great. Thanks, Roger.
Thanks, Carmen.